Can I have the first slide, please? Rheumatic heart disease perplexes all of us who are sitting in the audience every day. Every day in our hospital, we have 2 to 3 valve surgeries being done, single valves, double valves, and so on. And there are multiples of these waiting for valve surgeries. 40 years ago, we studied that 40% is the incidence of rheumatic heart disease in any tertiary hospital. We are in 2025, 40% is still the incidence. Is rheumatic heart disease a big problem? If we pause and then ask ourselves, World Health Organization, not that we attach a lot of importance to World Health Organization or United Nations these days, but we need to have some ballpark figure, says there are 55 million people, that is the prevalence, who have rheumatic heart disease, and approximately 1,000 people are dying of rheumatic heart disease every single day. Usually it means that it's not those elderly patients what we used to see in developed countries. We have these patients who are breadwinners who are succumbing to this disease, which we are unable to prevent. Now, traditionally, we were talking about 3 levels of prevention: primary, secondary, and tertiary. Over a few years, we have added primordial prevention and quaternary prevention as well. So as a surgeon, my perspectives on these will be from a preventive cardiology, because as I said, we are vexed with daily treating thousands of patients all over our country, and we have still many more to be treated in valvular heart disease. In primary prevention, we talk about health, education, and specific protection. Whereas in primordial prevention, we talk even addressing the risk factors. Whether this is possible in our country or not is a big question. But basically, we are saying improve the living conditions, improve the ventilation, prevent overcrowding, and nutrition. But my big question to myself is, if there are 5 children in a family, they all have the same ventilation, same overcrowding, same nutrition. Only one of them is developing the valvular heart disease, not everybody else. But anyway, as I say, this is a concept. How much of this can be translated into our country is a big question mark. When we talk about primary prevention of rheumatic heart disease, which if at all it works, it will wipe out, and possibly in my own lifetime, I will see that there are no more valvular heart disease cases, which is possibly a dream. People have thought of vaccines for rheumatic heart disease. But as we are talking in September 2025, there is no effective vaccine for rheumatic heart disease. The first reason is phenomenal strain diversity. Influenza also has strain diversity. Every 4 years, there is a pandemic, and every year there is an epidemic. But still, we have some vaccine for influenza. Whereas for the so-called Streptococcus pyogenes, which compared to viruses, technically it should not, but the reality is there are 250 strains, and not a vaccine is going to cover. The second reason is safety concerns, because in the very etiopathogenesis of rheumatic heart disease, we say the antibodies which are formed against the streptococcal antigens will have molecular mimicry, and the valvular antigens will have similarity. And therefore, if at all you are going to give a vaccine and increase the incidence of antibodies, whether are we going to increase the disease rather than decrease is another question. Third one is about safety concerns. And because M protein is the one which people have been targeting, they thought of looking at something else into carbohydrates of the Streptococcus pyogenes organism. The most important thing, of course, is lack of investment. There is not much of research which will go into rheumatic heart disease because there is no money in that. Not for all doctors, but Swami used to say, normally we say S1 and S2 is lub dub, lub dub, lub dub. In Telugu, if somebody has a problem, vaadu labo dibo mani mottukuntunnadu antam. Lub is labo, dub is dibo. But for several of the so-called corporate doctors, when you have a lub dub, the second heart sound only, there is no first heart sound. Dub, 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 dub. In Telugu, dubbu means money. So for that reason, the amount of that investment which goes into research is absolutely abysmal. But there is some hope. People are still trying. In New Zealand, Australia, they have got some tribes in which rheumatic heart disease is still rampant. And I leave you to study. There are some nice videos on Take Heart Quest for the Holy Grail of rheumatic heart disease vaccines. But as I say, I myself personally have no hope as of now. Where there is hope, I'll let you know very shortly. World Heart Federation, which has decided to do this in Prashanti Nilayam, is also associated with the vaccine research for rheumatic heart disease. So quickly, vaccines for rheumatic heart disease. The M protein vaccine, 30-valent M protein vaccine, looking at some other molecules, serum opacity factor vaccine. These are all there, but none of them have offered any promise. Then people have looked at secreted proteins of Streptococcus pyogenes as the second target where we may be able to develop some vaccines. Again, no luck. Then they looked at carbohydrates. Again, there is no luck. So the only area where hopefully a vaccine may come is what is called as reverse vaccinology. Now, we have seen that in COVID times, healthcare was given a very short time to develop vaccines, and we have developed vaccines in no time. So we have heard of in vitro research and in vivo research, but there is a term called in silico research. This is after silicon chips which go onto computers. So in silico research is just a computational modeling. So in this, the whole genome of Streptococcus pyogenes has been laid down. And in silico, that means using different open reading frames, the computational biologists will be looking at various antigens which can be targeted. And once we do that, there'll be screening of conservation of the targeted proteins, then the cloning and expression. The whole cycle of vaccine development starts, and human trials are yet to begin. When we talk about secondary prevention, we talk about early diagnosis and treatment. Both of them are, again, very difficult in rheumatic heart disease. We said health promotion, specific protection doesn't work. Vaccines are not there. When you come to secondary prevention, again, the news is not very good. In a large country like ours, to think of early diagnosis of rheumatic valvulitis is still remaining a distant dream. Why? I said 40%, 40 years ago, 40%, 25. That answers, that means we have not made any dent into the etiology. Benzathine penicillin still works as a good prophylaxis. In our own country, I keep getting calls from Assam, Orissa, and so on, that penicillin is not available for prophylaxis. There is a shortage. Then when I looked around, I found that it is not India, it is a global shortage of penicillin. So why are they not manufacturing penicillin? Because it is cheap. There is a high manufacturer cost. There is a low sale price. Dhanamulam idam jagat. If there is money, people will put into the industry. There is no money in penicillin. Nobody is bothered manufacturing it. Everybody is manufacturing monoclonal antibodies for cancers because there is plenty of money. One vial will sell at 2.5 lakhs. Penicillin is dead cheap. Therefore, there is no further research. And as I said, United Nations and World Health Organization, the less we say, better it is for our coronary disease. So when it comes to treatment, one thing which we should be proud of is the Indian-made TTK Chitra valve. I openly state that the myth that a single leaflet valve is worse compared to a bileaflet valve is a myth, because we have implanted tens of thousands of TTK Chitra valve. It is a phenomenal valve. So we should actually, wherever MS Valiathan and the former President Bharat Ratna APJ Abdul Kalam, they have worked in India, developed this, and it is a very good valve and competes very well. I think we should applaud their efforts. We have now started to export this valve. It comes in very good sizes for our Indian population. And there are people who say the thromboembolic complications of TTK Chitra valve are less than the bileaflet valves, which will sell 20 times, not in America, not in UK. The price is 20 times of this valve in India. So that is the paradox. When it comes to monitoring of INR, it remains a big challenge to have a patient who has got a stuck valve or somebody who is having intracranial bleed. Once in a while, we keep seeing, we feel so sorry because there is no standardization, there is no availability of this across. This is how it is made, and there is something to talk about the Haynes alloy as well. It prevents what we call as galling due to microscopic transfer of material. And in vitro studies have said that these valves will function for 200 years. That means they are good enough. With Center for Cellular Molecular Biology, we started to look at our own patients. And I asked all of you one question: why is it that out of 5 siblings, only one is having valvular heart disease? So there is a genetic variation among the children, among the same parentage family, individual to individual variation. And that, I think, will throw more light as the research focuses further. In pregnancy, traditionally, we have been taught that in first and third trimester, you would go back to the heparin. It is not really needed. There are some European guidelines on that. So a take-home message for all of you in your clinical practice: do not change the vitamin K antagonist at all. First trimester to second trimester, third trimester, nothing. Make sure that you'll get the TIFA scans in 20 and 24 weeks, and that is it. Please don't change, and please don't make things complicated. Do not implant biological valves because the lady is in reproductive age group. All that is past. We don't need to do that. When it comes to tertiary prevention in rheumatic heart disease, disability limitation and rehabilitation, that is where in the afternoon you will see the role of Sathya Seva organizations and how they are trying to do in primordial, primary, secondary, and tertiary, which is again a phenomenal experiment which is happening. We have an outreach because we go into every single district and samiti. We are able to follow up our patients and find out what's happening. We have telemedicine where we are able to monitor their INR, of course, given the lacunae of standardization. But then this is largely at the mercy of philanthropists because government agencies in remote parts of our country are absolutely helpless, and there is neither sustainability nor accountability. We have to depend on these NGOs and philanthropists to take things further. So the last term, the quaternary prevention, is where we have to avoid over-medicalization, drug-drug interactions and drug-food interactions and iatrogenesis, and ethically improved interventions like TAVR. Our American colleagues will say now TAVR can be used for anyone and everyone who has got aortic valve disease, which is pathetic. But then, as I say, from Indian scenario, we have to redefine where exactly are we going to do. When it comes to research, the news which I want to share with all of you is we have Sri Sathya Sai Institute of Higher Learning, a premier institute. And to remind all of you, the education there is absolutely free. A PhD student to primary student, who you have seen, some of them are in the audience here, they pay zero money as tuition fee. Their counterparts in the other universities pay up to 10 to 20 lakhs. So we have got formalization of the Memorandum of Understanding between Sathya Sai Institute of Higher Medical Sciences of both campuses with Sathya Sai Institute of Higher Learning, our own sister institute, for formalizing the research. Secondly, we have an MOU with University of Chicago for artificial hearts, transplants, and also the LVADs. The third thing is we have entered into Institute of Science Tokyo. We had again another memorandum of understanding for research. And just last week, we entered into an MOU with Rutgers in New Jersey, which is again a premier institute. The reason I am mentioning this is these are all recent developments, and hopefully we'll have a lot more to break our heads on, do research, and make sure that the common man's life will become much better than what it is today. Sai Ram. And in the interest of the coronary calcium score of the organizers, I will not take any questions.